Welcome back to the Deep Dive. Today, we are strapping on the headlight and stepping into the operating theater.
Getting our hands dirty.
We really are. We're tackling one of the true workhorse procedures in sports medicine, the bone patellar tendon bone, or BPTB, autograft for an ACL reconstruction.
Yep.
And this isn't just a quick overview. We're doing a meticulous, step-by-step dissection of the technique, really leaning on the insights from sources like Magnuson, DeAngelis, and Spindler.
I think that's the only way to do it. Our mission today is to move past the superficial summary and really get into the geometric and mechanical details, the nuances that distinguish a really solid ACL reconstruction from one that's, well, a compromise.
Especially for those high-demand athletes, the BPTB has been called the gold standard for a long time, and I think today we're going to dig into why that perception is still so strong, especially when you look at the data.
We are. And that starts with the big debate, right? It always comes down to BPTB versus hamstring grafts.
Exactly. The source material is really clear that a lot of high-level systematic reviews show they're functionally equivalent. If you just look at the outcomes, lysome scores, activity levels, a lot of studies say, hey, both methods work. Not a lot of clinical difference.
Right. On paper, it looks like a coin flip for your average patient.
So why isn't it?
Because that's where you have to distinguish between different types of evidence. We're talking about functional equivalence in randomized controlled trials.
Like RCTs.
So standard of research.
In many ways, yes. They're excellent for seeing if a patient can get back to their sport or achieve a certain range of motion, but they don't always capture the one thing an athlete fears most. Failure. Long-term failure. And that's where the story gets really interesting, and what swings the argument toward BPTB in certain circles. It's the mass population data.
Yeah, so you're talking about the registries, the huge databases from Scandinavia and places like precisely. The sources point out that these large recent registry databases, we're talking tens of thousands of procedures tracked over many years, they suggest that BPTB autografts might actually be associated with a lower risk of revision, a lower failure rate compared to hamstrings.
Wow, okay, so that's a huge divergence. The RCTs say they're functionally the same, but the real-world registries, tracking thousands and thousands of people, hint that BPTB might just be more durable.
It might be.
Why would that signal pop up in the registries but not the smaller studies?
It's a numbers game. Failure is, thankfully, a relatively rare event. So to detect a subtle but really significant difference, you need immense numbers.
I see.
The registries capture all those cumulative failures over time and across a much more diverse, real-world surgical population that, well, the strict rules of an RCT often leave out. So while the RCTs give us confidence in function, the registries are starting to give us evidence for long-term survival.
And that durability is really the reason we have to master this technique. For that patient who absolutely cannot afford a revision.
That's the one.
Okay, let's unpack this. Starting with the why behind choosing BPTB over other alternatives.
So the core rationale, it's really rooted in its biomechanics, specifically how it fixes in place and how it heals.
And that's what allows for those accelerated rehab protocols everyone wants.
Exactly. That's a huge selling point. So let's break it down. Benefit number one is the immediate fixation strength.
You're not waiting for soft tissue to slowly grow into bone here.
Not at all. You've got interference screws, whether they're metal or bioabsorbable, and they lock that bone block right into the tunnel wall. Think of it like a concrete anchor bolt. Once that screw engages the bone and presses it against the tunnel, you have immediate apical strength. It's not going anywhere.
And then benefit number two is the healing itself. It's bone to bone.
Correct. And that is fundamentally different and frankly superior to the tendon-to-bone healing you get with a hamstring graft, especially in that critical early phase, the first 6 weeks after surgery.
What's happening with the hamstring graft during that time?
That process is often called ligamentization. The tendon has to form this layer of fibrocartilage first, which then slowly mineralizes and turns into bone. It's just a much slower and initially weaker process.
So if we picture it like building a bridge, the BPTB graft is like anchoring the bridge into solid bedrock on both sides from day one. You can start sending traffic over it right away.
That's a perfect analogy.
Whereas the hamstring graft is trying to grow roots into a muddy riverbank, and that just takes time to solidify.
A lot more time. And that's why we can push early weight-bearing and aggressive range of motion much more confidently with BPTB. We know that fixation is rock solid from the moment we leave the OR.
Okay, and there's a third major advantage, which can be a deal breaker for certain athletes.
The hamstring preservation.
Right.
For an explosive athlete, a sprinter, a high jumper, anyone who relies on that rapid deceleration, The hamstrings are everything. They're not just for moving you forward. They're critical dynamic stabilizers for the knee.
They actively protect the ACL.
They do. They resist that anterior tibial translation. So if we go in and harvest the semitendinosus and gracilis, we're essentially weakening that built-in protective mechanism. For those athletes, BPTB means we aren't, robbing Peter to pay Paul. We're not compromising their kinetic protection down the line.
Okay, so that's a really compelling case for BPTB. Durability, early recovery, protecting other muscles. But every tool has its limits. So let's talk about the hard contraindications. When do we absolutely not use this graft?
Well, as great as the graft is, the donor site morbidity, the pain and issues where you take it from is the primary trade-off. And the number one contraindication is any patient who needs to do a lot of repetitive kneeling.
So occupational, recreational.
Or even religious reasons. These patients are just not good candidates.
Because of that chronic anterior knee pain, the patellofemoral pain, and especially that direct pain right on the front of the knee when they kneel down, it's a well-documented complication.
It is. And you're trading a robust ACL for what could be a nagging, permanent quality of life problem. If your patient is a plumber, a carpet installer, a gardener, you have to pivot to something else that just overrides all the biomechanical pros.
What's another non-negotiable?
A history of extensor mechanism problems,
Yeah.
any prior rupture, or even significant patellar tendon issues. I mean, we're already creating a weak point, a stress riser in the patella. If there's any pre-existing weakness, you are exponentially increasing the risk of a catastrophic complication.
Patellar fracture or patellar tendon rupture.
The worst case scenarios.
And then there are the anatomical limits, the things that might force you to change your plan on the spot.
Absolutely. This is where you have to be meticulous with your pre-op imaging and your intra-op measurements. A small patellar tendon is a big red flag. If the width is less than 25 millimeters, the source material says you should reconsider.
Because the remaining tissue might not be strong enough.
Exactly. Or if there's a big Osgood-Schletter ossicle right where you need to harvest. Anything that compromises the graft or what's left behind, that 25 millimeter threshold is really cited as the cutoff for a safe harvest.
But the material did mention a counterpoint to that, right? The note from Shelburne.
It did, and it's a fascinating piece of surgical history. It highlights that tension between established rules and, raw clinical experience. Shelburne and his colleagues reported in a personal communication that they've left as little as 14 millimeters of remaining tendon without it rupturing.
14. That's less than half the minimum standard. That sounds like surgical high-wire artistry.
It's definitely pushing the envelope.
So what does that anecdote tell us? Is the 25 millimeter rule just too conservative?
I think it tells us that the tensile strength of that remaining tendon might be higher than we assume, but only if the tissue quality is perfect and the harvest is absolutely flawless.
A lot of ifs.
A lot of ifs. The 25 millimeter rule is the standard for a reason. It builds in a safety margin for variations in tissue quality, patient activity, and minor geometric imperfections in the harvest. For the vast majority of surgeons, you stick to the rule. A width under 25 millimeters should make you stop and immediately pivot your graft choice.
I like framing these contraindications like a pre-flight checklist.
That's a good way to put it.
You're about to perform this complex maneuver, and if you skip checking the tendon width or you don't ask about their job, you're just building turbulence into their recovery. You just can't take off if one of those red flags is up.
Well said. So now, moving into the OR, the prep phase. A meticulous setup is just. It's foundational for a smooth case. The patient is supine, we've got a proximal thigh tourniquet. The whole goal is to maximize our access to the joint, especially for when we start drilling tunnels later.
The table position seems simple, but the details in the source material are really specific, especially about neurovascular safety.
It's one of those things you can't get wrong. You either flex the foot of the table way down past 90 degrees or just take it off completely. But here's the critical detail. The patient has to be shifted so their distal thigh hangs 3 to 4 inches beyond the edge of the table.
Why that specific overhang? 3 to 4 inches, what does that do?
When you flex that knee up to 90 degrees or more to drill, you're compressing everything in the back of the knee. By having that thigh hang over, you reduce the anterior displacement of the popliteal artery and the nerve. You're creating space.
So you're basically giving the neurovascular bundle a path of less resistance, moving it away from where your drill might be going.
Exactly. It's a low incidence risk and injury there, but it's a devastating high consequence one. You build in safety from the very beginning.
And what about the other leg, the non-operative one?
Meticulous padding. That contralateral limb needs to be protected, especially the common peroneal nerve and any bony prominences. I mean, this can be 2-3 hour procedures. You can't have a compression injury on the other leg because you weren't paying attention.
So once the patient is perfectly positioned, we go straight to the diagnostic scope. This is our final survey before we make any irreversible cuts.
And it has to be systematic. You inspect and grade every articular surface in a standard order: patella, trochlea, both tibial plateaus, both femoral condyles. You're hunting for any unstable cartilage flaps, loose bodies, or chondral lesions that maybe didn't show up clearly on the MRI.
This is also your chance to do any necessary tune-ups before the main event.
Right. You treat the cartilage flaps, you pull out any loose bodies. If you find a small, contained lesion, you might do a marrow stimulation technique like a microfracture or an abrasion. You want to optimize the joint environment before you put the new graft in.
You don't want a piece of loose cartilage floating around, potentially getting jammed in your new ligament.
You absolutely do not. And of course, you have to thoroughly check the menisci, both horns, the periphery. You inspect and you probe everything.
What's the general philosophy on meniscal tears found at the time of an ACL reconstruction?
The standard is to preserve meniscus whenever possible. So small, stable, partial thickness tears, we generally leave those alone. But if you find a repairable tear, say a vertical longitudinal tear in the red zone, an ACL reconstruction is the perfect biological environment for it to heal. You have to repair it.
Because a meniscectomy just starts the clock on early arthritis.
It absolutely does. You do everything you can to save it. So only after you've documented and treated all that concurrent pathology do you move on to the actual graft harvest. The foundation has to be flawless.
Okay, now for the main event, graft procurement. For BPTB, it's all about an atraumatic harvest, keeping the strongest possible bone-tendon attachment and protecting what you leave behind.
That's the trifecta.
The source material seems to prefer a single longitudinal incision.
It does, and for a very practical reason. It gives you the easiest visualization of the whole patellar tendon and both its bony attachments. That incision usually runs from about a centimeter proximal to the anteromedial portal right down to the tibial tubercle.
And once you're through the skin, you find and divide the peritoneum, that fascial layer. This is where you make the critical sizing decision.
Right. With the knee flexed to 90 degrees, you apply the rule of thirds. The BPTB graft should be no wider than 1/3 of the entire width of the patellar tendon.
So for a standard 30mm tendon, you're taking a 10mm graft.
Exactly. If the tendon is a bit smaller, say 27 millimeters, you adjust down to a 9mm graft. You always respect that ratio.
And this is where that 25mm hard stop comes into play. If the whole tendon is less than that, you abort.
You abort the BPTB plan. Absolutely, that's our standard. Despite that fascinating anecdote about leaving only 14 millimeters, we stick to the rule. Once you've marked your width, you divide the tendon part first with a scalpel, making sure you follow the fibers perfectly, all while the knee stays at 90 degrees.
All right, onto the bone blocks. This feels like the most technically demanding part of the harvest. Let's start with the patellar side, since that's where the risk of fracture is highest.
It demands meticulous attention. You mark out your plugs with electrocautery, usually about 20 to 25 millimeters long. And here's a critical safety pearl. We'll call it Pearl 7. You must preserve a minimum of 1 centimeter of intact proximal patellar bone above your cut line.
Non-negotiable.
Non-negotiable. It's your main defense against a post-op patellar fracture.
And when you take the oscillating saw to it, the cuts are very specific.
Very. The max depth should be shallow, maybe 6 or 7 millimeters, and the vertical cuts have to be angled in towards the center of the patella. This is what creates that essential trapezoidal shape for the bone block. This is Pearl 4.
So it's not a rectangle. It's wider on the outside and narrower on the inside. Why is that so important?
That geometry minimizes the cross-sectional area of bone you're harvesting. It reduces the stress risers you leave behind in the patella. It's an engineering principle applied to biology.
So what's the geometric mistake, the cardinal sin that leads to a fracture?
It's ting the cuts. It happens when a surgeon doesn't angle those vertical cuts inward and instead makes them too deep or square at the corners. You create these sharp 90-degree internal angles, and that becomes a hinge point.
A built-in breaking point.
That's exactly what it is. And when the patient starts firing their quad post-op, that hinge point can just pop. So, trapezoid shape, preserve the proximal bone.
After the saw cuts, you elevate the block. The source stresses using gentle elevation.
Brute force has no place here. It's an art. You use a 1/4-inch osteotome, tap it gently just into the horizontal cut, and then the block is lifted with what they call 2-finger pressure.
Just minimal leverage.
Minimal. There's actually literature showing that vigorous tapping, like you might use for other procedures, can generate enough force to cause chondrocyte death on the articular edge. You have to be delicate.
Okay, so the patellar side is a delicate trapezoidal extraction. How does the tibial bone block harvest differ?
It's a little less fraught with danger because there's no articular cartilage right there, so you can be a bit more aggressive, but you still need precision. We usually use half-inch osteotomes for the vertical cuts and a quarter-inch for the distal horizontal cut.
And a placement of that proximal cut on the tibia is key for getting enough length.
It is. You have to make sure you start right at the insertion of the tendon into the bone. If you start too high up, you end up with a piece of bone that isn't attached to the tendon, or your block is just too short. And the shape here is different. It's generally more triangular. That's the other half of Pearl 4.
So a trapezoid up top and a triangle down below. Why the triangular shape distally?
The triangular shape is designed to maximize the remaining bone attachment for the parts of the tendon you're leaving behind. It gives the residual tendon a wider base to insert on, maintaining the stability of the whole extensor mechanism.
And once the graft is out, you have to manage those defects. What's the standard for closing the patellar tendon?
It's closed meticulously with interrupted figure-of-8, heavy, absorbable sutures. And this part's important. You have to do the closure with the knee flex to 90 degrees to get the tensioning just right.
And what about the bone defects?
You don't just leave them empty. You take the bone dust, the shavings, all the little fragments you created while preparing the graft, and you pack them back into both the patellar and tibial defects. This promotes better bone healing and, according to Pearl 7, actively decreases that long-term fracture risk.
Okay, so now we step away from the patient for a moment and head to the back table for graft preparation. This is the quiet phase that can make or break the next steps.
This is where we fine-tune the engineering. The graft is kept moist, usually tacked to the drape so it doesn't get dropped or contaminated. The whole goal is sizing it for a perfect, snug fit in the tunnels.
And there's a specific sizing caveat if you're planning on using a graft passer.
That's right. A graft passer is basically a little plastic sleeve to help guide the bone block into the tunnel. If you're using one, you have to downsize the femoral bone block by 1 millimeter.
So for a 10 millimeter tunnel, the femoral block gets trimmed to fit a 9 millimeter sleeve.
Exactly. This just ensures it passes smoothly without getting stuck or shaving off bits of bone. The tibial block, which goes in without a passer, stays at the full 10 millimeters.
Let's talk about the suture holes at the end of each block. The source material makes a point that the placement is surprisingly high stakes.
It really is, and it depends on what suture you're using. If you're using a standard suture that could get cut by the interference screw, you have to place the 2 suture holes perpendicular to each other.
For redundancy.
Purely for redundancy. The idea is that if the screw cuts one suture, the other one, being on a different axis, will survive to help you position and tension the graft.
And if you're using something like fiber wire,
Then you can just drill them straight through. That stuff is so tough it's not going to get cut. But either way, you make the holes just big enough for the needle to pass through. You want to minimize any extra stress risers in the bone block itself.
all right, graft is prepped. We're back to the knee to manage the notch. And this is where we get into one of the most interesting debates in ACL surgery right now. What to do with the ACL remnant.
It's a real philosophical divide. On one side, you have surgeons who argue for preserving as much of the native ACL tissue, the stump, as possible.
Why? What's the thinking there?
They argue that this tissue can help with graft healing, bring in a blood supply, and more importantly, it might preserve mechanoreceptors.
So better proprioception, better joint position sense.
That's the theory. Better feedback for the patient. But on the other side, you have the clearance camp.
Who prioritize a clean slate.
They prioritize geometry and certainty above all else. They argue that leaving the stump just gets in the way. It compromises your visualization. And if you can't clearly see your anatomical landmarks for tunnel placement, you're risking malpositioning, which is the #1 reason for revision surgery.
So regardless of which camp you're in, you have to clear enough tissue to see what you're doing.
That's the bottom line. You have to debride enough of the ACL remnant and the Hoffa fat pad so you can perfectly visualize your tunnel entry points. If you can't see the landmarks, you can't be anatomic.
And that leads right into the notchplasty check. You have to make sure there's enough room for the new graft.
A critical safety step. The rule of thumb in the source material is that you should be able to easily pass a 5.5 millimeter burr between the lateral wall of the notch and the PCL, with a few millimeters of space. If it's too tight for that burr to pass freely, you need to do a notchplasty.
You do that initially for visualization, but you have to check it again later.
You absolutely have to. It must be rechecked after the graft is fixed. You put the knee through a full range of motion while watching on the scope. If that graft tissue rubs or pinches on the notch wall at any point, you have residual impingement and you have to take more bone.
Because failure to do that is just setting the graft up to fray and fail over time.
It's a classic pitfall. You're just slowly sawing through your own reconstruction.
This section really feels like the engineering phase of the surgery. And it all starts with that tibial tunnel.
The geometry has to be perfect, non-negotiable. With the tibial tunnel, the goal is to get it right in the middle of the native ACL footprint.
You're trying to avoid two big failure modes.
Right. You don't want anterior or lateral impingement on the notch when the knee is straight in extension, and you don't want the graft wrapping around the back of the PCL when the knee is in deep flexion.
So what's the standard recipe for the aiming guide on the tibial side?
Typically, you set your guide to an angle of 50 to 55 degrees relative to the tibial plateau. You want the tip of the guide pin to land at the posterior edge of the anterior horn of the lateral meniscus and centered right between the PCL and the lateral wall of the notch.
And what about the starting point on the outside of the tibia?
It has to be far enough down to leave a good, strong anterior bone bridge. If you start too high up, you risk blowing out the front of the tibia when you ream the tunnel.
You also have to watch out for the local anatomy.
Absolutely. Too far medial and you're in the pessaman tendons. Too far lateral and you're getting close to the patellar tendon insertion. You have to find that sweet spot.
Okay, now let's pivot to the femoral tunnel. This is where a real revolution has happened in the last couple of decades. We used to just talk about the clock face.
The clock face, it's becoming, well, almost obsolete for precision, even though we still use it for general location. The classic teaching was to put the tunnel at 10 o'clock or 2 o'clock, depending on the knee.
But those were very vertical tunnels.
Very vertical. And we found they were great at controlling a simple Lachman test that's straightforward in back motion, but they were terrible at controlling rotational instability.
The pivot shift, the thing that actually makes a knee feel unstable to a patient.
Exactly. So modern anatomic placement has pushed that tunnel farther down the lateral wall. Now we're talking anywhere from 11 o'clock all the way down to 9 o'clock for a right knee.
So the goal is to change the trajectory from vertical to more horizontal. Why does that make such a big difference?
A more horizontal graft more closely mimics the native posterolateral bundle of the ACL. And that's the part that's the primary stabilizer against rotation. By getting that angle right, we're better able to eliminate that pivot shift phenomenon, which is the true goal of the surgery.
But the source material points out that the single most important factor isn't even the clock face position.
No, it's not. The most critical variable is the anteroposterior, or AP, position. Where you are from front to back on the femur influences the graft's tension, its isometry, more than anything else.
If you're too far forward, the graft gets super tight in flexion and loose in extension.
And it just stretches out and fails.
Yeah.
The recommended AP position is meticulous. For a 10-millimeter tunnel, you want to be 7 millimeters anterior to the over-the-top position at the very back of the femoral notch. That is a master control knob.
Getting to that perfect spot brings us to the 3 different drilling techniques. Each one has major trade-offs. Let's start with the old school method.
Number 1, the transtibial technique. This is the simplest. You basically just drill your femoral tunnel through the tibial tunnel you already made.
Pros. It's easy, it's fast, you don't need another incision.
But the con is a deal breaker for many. It's a geometric constraint. The path of your tibial tunnel severely limits where you can place your femoral tunnel. It physically prevents you from reaching that lower, more posterior, more anatomic position.
So the transtibial technique is what gave us all those vertical, non-anatomic grafts for years.
For the most part, yes. It often falls short of the ideal, which is why surgeons developed independent drilling techniques. First up was the accessory medial portal technique.
This was designed specifically to get around that vertical graft problem.
It was. You create a separate little portal anteromedially, and that lets you aim your drill guide lower and farther back on the lateral wall. But to get the angle right, you often have to hyperflex the knee, sometimes past 120 degrees.
And what's the big risk with that technique?
The big risk is iatrogenic cartilage damage. You're working in a tight space, and it's very easy for your drill or your guide to scuff up the articular cartilage on the medial femoral condyle. You can literally score the joint surface.
Not ideal.
Not ideal. And because the knee is so flexed, the tunnel can end up being a bit short, so you often have to drill all the way out the other side through the lateral cortex to get enough length.
Which brings us to the third option, the one that gives you the most freedom, the two-incision technique.
This is really the modern standard for maximum precision. It lets you place the femoral tunnel completely independently of the tibial tunnel or any portal constraints. The data shows it's just superior at reproducing the native ACL insertion site.
So walk us through it. How does it work?
You use an outside-in guide system. A little stylus goes in through your anteromedial portal, and you place it on that perfect spot on the femur, that 7 mm mark. The guide handle then tells you where to make your incision on the outside of the thigh.
A second, separate incision.
A 2 cm incision on the anterolateral thigh. And from there, you drill outside in, antegrade, directly to that point.
And with this technique, you're almost always drilling through the lateral cortex.
You are. It's a deliberate choice. You're trading the morbidity of a second small incision for maximal anatomical accuracy. For many surgeons, that's a trade worth making.
Okay, we've got geometrically perfect tunnels. Now we have to get the graft in there. This is the part that can either go smoothly or become a huge headache.
It's the moment of truth. You pull the sutures through the tunnels. The path depends on how you drilled, but the goal is the same.
What are the common sticking points? Where does the graft get hung up?
The most common is getting that proximal bone block into the femoral tunnel, especially if you forgot to downsize it by that 1 mm, or getting the tibial block to engage in the tibial tunnel.
And if you're using a graft passer, you're only putting the femoral block into it.
That's right. The smaller femoral block goes in the passer, and the full-size tibial block engages the tibial tunnel directly. You just have to be patient and guide it in.
Once it's passed, we move to fixation. For BPTB, the interference screw is king. Why is it so much better than things like buttons or posts?
It provides the most rigid apical fixation. That rigidity is key. It minimizes micromotion at the healing site. Plus, other systems, especially on the tibial side, are known for causing more post-op pain from the hardware. The screw is fast, rigid, and generally causes fewer long-term issues.
Let's talk about gap science. This is how you pick the right size screw.
It's an exact science. You're essentially using the screw as a wedge, so it's based on the gap between your bone block and the tunnel wall. A 1 mm gap gets a 7 mm screw. A 2 mm gap gets an 8 mm screw. 3 to 4 mm, you need a 9 mm screw.
And you might go a size up if the bone feels soft.
You might, just to get better purchase. And the screw has to be flush with the cortex and never longer than the bone block itself. If it sticks out past the bone, it'll shred the tendon part of the graft.
Okay, femoral fixation usually happens first. And the technique is different depending on how you drilled the tunnel.
Right. If you use the older transtibial or the medial portal technique, the fixation is retrograde. You're putting the screw in from inside the joint.
And what's the big warning with that?
The risk of graft laceration. As you're manipulating that screw from inside the joint, there's a small but real chance that the threads can catch and cut the soft tissue part of your graft. A disaster.
But the two-incision outside-in technique allows for antegrade fixation.
Which eliminates that risk, and that's a huge advantage. Here, the screw goes in from the outside, following the path you drilled. The only trick is you have to pull on the proximal sutures to keep the bone block seated while you're putting the screw in.
Femoral side is locked in. Now for the tibia.
Tibial fixation is last, and it's done under tension. We don't know the exact perfect amount of tension, but the clinical goal is to pull back on the graft enough to translate the tibia as far back as it can go against the PCL. You want to eliminate any residual laxity.
And what position is the knee in for this?
Typically, either full extension or about 20 degrees of flexion. This ensures the graft isn't loose when the patient is up and walking. You secure that tibial screw and you're almost done.
Almost. Then comes the final check.
The real moment of truth. Both screws are in. You range the knee from hyperextension all the way up to 100 degrees of flexion. You do a manual Lachman test right there on the table to confirm it's stable. And then you do a final look with the scope to make sure there is absolutely zero impingement.
And if there is,
you fix it, you go back and do more notchplasty. If it's still loose, you have a much bigger problem on your hands.
All right. Assuming we have a rock-solid, non-impinging graft, we move to closure. And this is all about managing that donor site morbidity.
Meticulous irrigation first, always. Then you start the layered closure. First, you place those harvested bone fragments back into the patellar defect, then the rest into the tibial defect. You're jump-starting the healing process.
Then the patellar tendon closure.
Right. Done with those heavy, absorbable figure-of-8 sutures. And remember, you do this at 90 degrees of flexion to get the tension right. For the skin, we use deep dermal sutures and a subcuticular running suture for a nice cosmetic closure.
Let's talk about the post-op protocol. Because of that rigid bone-to-bone fixation, BPTB rehab is often called accelerated. What does that actually look like?
Well, the immediate goals are the same for everyone. Control pain and swelling, get full extension, get the quad firing. But the accelerated part means immediate weight bearing as tolerated.
No waiting period.
No. The bone plugs are fixed so robustly. Patients are on crutches only until they can walk without a limp. For many, that's just a few days.
And no routine brace.
We don't routinely use one? No. The fixation is that good. The only exception is if the patient had a nerve block for pain that's making their quad weak. Then we might use a brace for a day or two just for safety.
Of course, that all changes if you did a meniscus repair or a microfracture.
Of course. A meniscus repair will limit your flexion for a month. A microfracture means protected weight bearing for 6 weeks. You always have to tailor the rehab to the whole procedure, not just the ACL.
So to wrap this all up, let's just synthesize this whole process. Let's revisit the key clinical pearls and pitfalls that a surgeon has to have burned into their brain for this technique.
Let's start with Pearl 4, anatomic shaping. You have to remember the geometry of the harvest. The patellar block is trapezoidal to minimize stress on the bone you leave behind. The tibial block is triangular to maximize the insertion area for the tendon you leave behind. Getting those shapes wrong is just asking for trouble.
And the biggest risk during the harvest itself.
Pitfall 3, harvest integrity. The absolute meticulous attention required to avoid breaking the patella or damaging the graft. That means shallow saw cuts, gentle elevation, that whole 2-finger pressure technique.
And finally, that non-negotiable safety margin.
Pearl 7, donor site protection. You must preserve at least 1 centimeter of proximal patella bone stock. That is your firewall against fracture. And putting the bone graft back in the defect helps rebuild that firewall over time.
So what does this all mean?
It means that an ACL reconstruction with BPTB it's like surgical choreography. Success is defined by a whole series of millimeter-level precision checks. That 7-millimeter AP position, the 2-millimeter gap for your screw, the 1 centimeter of bone you leave behind, every single detail has to be controlled to get that durability we see in the registry data.
So while the functional debate with hamstrings will probably continue, the superior biomechanics early on and that mounting registry evidence for lower failure rates, it makes mastering BPTB essential, especially for that explosive athlete who can't afford to lose their hamstring function.
That's the trade-off. You're accepting the known risk of some anterior knee pain in exchange for maximum mechanical reliability and the fastest path to a solid structural repair. It is a true high-reliability workhorse.
You know, this whole procedure, it's about constantly making choices. And that discussion about the ACL remnant brings us back to that core conflict that's still unresolved. Do you preserve the native ACL stump, hoping to keep some of that proprioceptive feedback? Or do you clear everything for a perfect view, guaranteeing the most accurate tunnels possible? You're literally choosing between a theoretical neurological benefit and surgical certainty. So the deep dive question for you to think about is, what value would you place on that potential mechanoreceptor preservation versus the guarantee of surgical certainty? That's the question you have to answer for every single patient you see.